You can also do an interop call. These systems all have some way of measuring the pedicle, like either through the tap or whatever you insert, you can kind of measure how much you put in so you'll know the screw length. And the other thing is it's diameter, right? Because it's very important because all those little channels, they come in different sizes of diameters, right? So you can have a small pedicle or a bigger pedicle or a really big pedicle. And to maximize fixation, you want to use the biggest screw possible. So we also do that. We also look at not only length, but width. Okay, back to you.
Okay, I've got two questions. If you're using multiple levels and you're going in knowing you're going to use multiple levels, can you use one long rad for multiple levels, or do you have to use individual rads for each?
No, most times when we fuse, it's a contiguous fusion. Very rarely will we fuse a segment up top and then have some mobile segment and a segment below. And the reason we don't do that is that it was a question that you asked, right? If you fuse a segment above and you fuse a segment below, we're afraid that the ones in the middle are going to degenerate, and we can't predict that. So we'd like to do it contiguously. So we typically use a rod that will span all the segments, one rod. Did that answer your question?
Yes.
Now remember, I skipped you. Do you have a question?
So, like in general, besides osteoporosis, is there any other contraindications to that surgery?
Osteoporosis is a big contraindication. So a lot of times we'll pre-medicate them with Forteo or some type of bone building drug. I think that is the most difficult patient, the patient that's osteoporotic when we're trying to do this type of instrumentation. Okay. The other contraindications are really more kind of surgical contraindications, how old they are, what's their health status, what their weight is, what their BMIs are. It's really typical kind of surgical constraints. Smoking, there's not many bad things you can do for spine fusion. Smoking has been found to be detrimental for spine fusion. So if you're trying to fuse somebody, it's very difficult if they're smoking. Their risk of not fusing goes up astronomically. So a lot of these patients, when we're doing multiple levels, we will force them to quit smoking. A lot of times, if they don't quit smoking and we'll do a nicotine test on their urine, we don't do it. Okay, that's really how important it's become. Okay, question in the back?
So I have a question about the first procedure. So let's say like a patient is not suitable for surgery, or for some reason they cannot just get the surgery. Is there like a non-surgical treatment, or what would be the consequences of not having the procedure done on
in the first one?
Yes.
Okay, so it's amazing. When you have a disc herniation and you either have sciatica, buttock pain, or leg pain, or people say sciatica, you've probably heard disc herniations before. Most of those will heal on its own. So 85% of patients typically, if they come in and they have radiating pain down the buttock or the leg, and you take an MRI and they have a big disc, we wait. Because after that happens, in 2 months' time, if you follow these patients out, 85% will just get better naturally. The body has its own healing process, okay? Now, what happens after that first 2 months, if you wait another 6 months, another 5% get better. So we kind of do surgery within 2 to 6 months, because if you're in significant pain, it's really hard to wait 6 months, obviously. If your pain starts getting better, a lot of people just wait it out and it resolves, okay? So to answer your question, it is, if you can't get it, it doesn't mean something horrible happens. A lot of times you just have to deal with the pain, and in many cases it just gets better. Typically, we're forced to do something because there's weakness involved, and weakness has a little bit of a time constraint. So if you have significant weakness, okay, we know that the earlier the operation that we do and we decompress the nerve root, the more potential strength that you can recover. So if you have significant weakness and you wait 6 months to get it treated, there's a likelihood that that strength will not fully recover. So that's why, sometimes we do surgery earlier. It's not really so much for pain. Pain is kind of what you can tolerate. Some people can tolerate a lot of pain, some people cannot. But weakness is something that surgeons would start recommending surgery because we're trying to protect the nerve. And the nerve has a time constraint to it. The longer you wait, a lot of times the nerve will not get full regeneration. Okay?
We're going to take one more question, and then Dr. Anand is going to give his lecture.
Great. You. It's fine. Oh, back there. Sure. No, go ahead.
Okay, so when you're fusing multiple levels of the spine, for the sake of conserving resources, do the screws have to be in each level, or can they be,
Good
can you
question.
skip
Yeah.
a level?
So the quick answer is they do not have to be in each level. Okay. We typically put them in, we do put a lot of screws in because it's really hard to judge, and the US system is a way where it's all overkill, right? We do everything possible. So we really don't know the answer of how many screws that we can put in. So we tend to kind of do everything, but absolutely it does not need to be in every level.